By the name of God, I would like to present this lecture, which is the fourth lecture in the infectious module for the third stage in the Baghdad Medical College. I am Mazen Joud Ibrahim, the assistant professor in the medicine department. Contents of this lecture: first one is discussion of the food poisoning and its management. Botulism, tetanus diseases. Also, we discussed these diseases in this lecture regarding the clinical features and also the management. Also, I will present cases regarding these diseases. We start now with the food poisoning. Acute vomiting and diarrhea can be caused by infection, of course, but not only this infection is the only etiological factor. Other causes could be the etiological factor for acute vomiting and diarrhea. For example, certain gastrointestinal disease like the inflammatory bowel disease. Or metabolic cause also could be multiple long list of metabolic causes, for example, thyrotoxicosis. Also, the ingestion of certain drugs or toxin, for example antibiotics, can give also to acute vomiting and diarrhea. Now, what are the sources of food that give rise to the food poisoning? Multiple food items can give rise to food poisoning. For example, the raw seafood, raw eggs, undercooked meat and poultry, unpasteurized milk and juice, also unpasteurized soft cheeses, and homemade canned goods, raw hot dogs. All these can be the source for the infection. For example, the raw seafood can be a source for certain viruses like the norovirus, hepatitis A virus, and also for the Vibrio cholera species. All these can give rise to food poisoning caused by the raw seafood. Raw eggs can be the source of Salmonella species. Undercooked meat and poultry can be the source of Salmonella, Campylobacter, Escherichia coli, also Clostridium perfringens, and also the unpasteurized milk and juice can be the source for the Salmonella and Campylobacter, E. coli, which is the hemorrhagic strain of the E. coli, Yersinia enterocolitica. Unpasteurized soft cheeses could be the source also for the Salmonella and Yersinia, Listeria, Campylobacter, Escherichia coli. Homemade canned goods can be the source for the Clostridium botulinum, and also the raw hot dogs could be the source for the Listeria monocytogenes. For example, in this case, after a celebration in a party, a few persons have been admitted to the emergency room 4 hours after they left the party. Because of number of persons affected after certain food used in the party, ingested in the party, so there is suspicion of food poisoning. These patients have repeated vomiting followed by abdominal pain, watery diarrhea without fever. Now, what is the appropriate approach? What is the proper approach for the patient with food poisoning? First thing, of course, like any other disease, we have to take the history from the patient. The important points in the history first is the duration of the illness. That's to say, what is the incubation period of the disease, and for how long the clinical features. Also, the source and type of the food is important, whether family or community members have been affected, also in addition to the patient. Duration, characteristic, and the frequency of diarrhea are important points in the history. Presence of blood and mucus in the stool, abdominal pain if it is present, also tense mass. Also, have to ask about the fever, and we have to ask the features of the diarrhea, whether it is bloody with the fever, then there is suspicion of the invasive dysenteric process. Why incubation period is important? Of course, it is important because it gives an idea about the microorganism implicated in the etiology of the food poisoning. For example, if it is less than 6 hours incubation period, now we suspect, or we have a suspicion regarding the enterotoxin produced by certain bacteria and infectious agent like Clostridia species, Bacillus cereus, and Staphylococcus aureus. While in condition of the incubation period about 12 to 72 hours, Now there is suspicion of the enterotoxigenic Escherichia coli, or because of the Shiga toxin that produced by the E. coli, or enteroinvasive E. coli, also Vibrio cholera, Salmonella, Shigella infection, Campylobacter, Clostridia. All these can give rise to food poisoning with incubation period about 12 hours up to 3 days. Viral infection always gives short incubation period, and these viruses like rotavirus or norovirus. Protozoal infection, this gives a long incubation period, for example in giardiasis, cryptosporidium infection, amoebic dysentery, isosporiasis, and microspordiosis. Most clinicians consider a foodborne illness when a patient presents with gastrointestinal symptoms, including the nausea, vomiting, abdominal pain, diarrhea, and fever. However, patients with foodborne illness may present initially with other complaints. These complaints away from the GIT symptoms, such as what? Such as neurological symptoms. So the patient may have food poisoning, but the presentation is headache, paralysis, tingling. Sometimes the patient presents with hepatitis features, or even sometimes the patient may present with renal failure. Okay, so the presentation of patient after food poisoning could be related to GIT symptoms or could be related to symptoms of other systems. Now, how is food poisoning is diagnosed? Most times, the diagnosis of food poisoning is made by history. History is very important point for diagnosis of food poisoning. In addition to the history, stool examination is very important. Now, what are the criteria of the stool important for the diagnosis of the cause of food poisoning? Macroscopic examination of the stool, it is by inspection. Whether presence or absence of the blood is important. Also, microscopic examination is important for the leukocytes. Stool culture should be performed where possible, but often the results will come too late to influence the immediate management. When the patient presents with food poisoning, he needs immediate treatment, immediate management. Stool culture sometimes is required, but this stool culture, of course, it may be late with its result. So sometimes we use stool culture also. In addition to the stool examination, full blood count is important. Serum electrolytes also indicate the degree of inflammation and dehydration. Immunological tests sometimes required, especially for detection of certain toxins like the Shiga toxins. Blood and urine cultures and chest X-ray may identify alternative sites of infection, particularly if the clinical features suggest a syndrome other than gastroenteritis. Now, what other points are important in the examination? The degree of dehydration can be assessed by skin turgor, and the blood pressure also is management. So, the degree of dehydration and blood pressure are important points regarding the patient with food poisoning. The urine output and ongoing stool losses should be measured also carefully. Now, what are the proper food poisoning treatment? Isolation of the patient is required for patient with food poisoning. Why? Because this patient may be the source of infection to other persons in the family. What are other measures that should be done for this patient? Of course, rehydration. Rehydration is very important. Why? Because the patient with dehydrated has liable for many complications. So replacement of the fluid losses in diarrheal illness is crucial and may be life-saving. And the fluid replacement can be achieved with either oral rehydration solution or in severe dehydrated IV fluid should be given. Infected mucus is capable of a very rapid fluid and electrolytes. The infected mucosa is capable of very rapid fluid and electrolyte transport. if carbohydrate is available as energy source. So the oral hydration solution contains the sugar for this purpose, as well as the water and electrolytes are required. So oral hydration solution is very important point to prevent the dehydration for the patient. But in severe condition, we have to give IV fluid rather than oral fluid. In very sick patients or those with cardiac and renal disease, monitoring of the urine output and central venous pressure may be necessary. The volume of fluid replacement required should be estimated based on three important considerations. The first one is the replacement of the established deficit, fluid deficit. Second thing is replacement of ongoing losses because the patient, when he has food poisoning, may have continuous diarrhea and vomiting. The other important thing is replacement of normal daily requirement for the fluid. Now, what is the role of antibiotics? Antibiotics are recommended for some, but not for all patients with food poisoning and gastroenteritis. And also evidence suggests that a specific strain, that is hemorrhagic strain of Escherichia coli infection, the use of antibiotics may make the complication of hemolytic uremic syndrome, which is very dangerous complication in the patient with food poisoning, more likely due to increased toxin release. So the antibiotic sometimes is not only not required, but sometimes it's toxic and lead to certain complications like hemolytic uremic syndrome. Antibiotic should therefore not be used in this condition. Conversely, antibiotics are indicated in Shigella dysentery infection and invasive salmonellosis, in particular typhoid fever. So, the use of antibiotic is not required in each gastroenteritis caused by food poisoning, but required in certain bacterial infection. Antidiarrheal drugs, antimotility, antisecretory agents. These agents are not usually recommended in acute infective diarrhea, like the loperamide, diphenxylate, and opiates are potentially dangerous in dysentery in childhood, causing why? Because it may lead to intussusception. Antisecretory agents like the bismuth and chlorpromazine may be effective but can cause significant sedation. Absorbent drugs like the kaolin and charcoal have little effect. So, the most important point in condition of food poisoning is the fluid replacement, plus minus antibiotic, plus minus antidiarrheal or antimotility or antisecretory agents. Now we discuss another disease, that is botulism. An example and case scenario for botulism disease. 62 years old housewife was admitted to the hospital with nausea and vomiting and abdominal cramps. This patient, 62 years, presented with nausea and vomiting and abdominal cramps that have become severe. She had difficulty in speaking and was unable to respond, a blurred vision, and difficulty swallowing also when they were having lunch. Upon assessment, drooping of the patient's eyelid and facial muscles on both sides of her face. Vital signs were stable with blood pressure about 120 over 80, pulse is 82, temperature is about 98 Fahrenheit. However, respiration rate was shallow or less than normal, is about 10. So regarding this case, the patient presented with nausea and vomiting and abdominal cramps but neurological features, and the neurological test showing deficit on both sides of the body. Her daughter mentioned that she had eaten in the last few days cans, her own vegetables, and had eaten from one of the jars. She begins to have weakness in her arms and legs. Paralysis starts developing in her upper extremities, and soon after, breathing ceases. Now, she was placed on a ventilator when she was received in the hospital. The results of the CT scan are normal, showing no signs of stroke or hemorrhage. The blood work, however, comes back showing positive for toxins. So this case, old age female, she had clinical features of vomiting, diarrhea, GIT symptoms together with abdominal pain, and then developed neurological features. And when received, she put on ventilator, but she has history of eating cans before she came to the hospital. The suspicion here, because of her neurological features, is the stroke. CT scan done for her showing no stroke or no hemorrhage in the brain. In this condition, we have to suspect the presence of botulism because this patient has botulism by ingestion of the Clostridium botulinum, which is present in the food. This bacteria can give rise to neurotoxin, giving rise to the neurological features. Botulism is a syndrome of paralysis and neurological dysfunction produced by neurotoxin of Clostridia botulinum. This organism may contaminate many different foodstuffs, from canned meat and salmon to home-produced and preserved vegetables. So different types of food can give rise to this, may be contaminated by this bacteria and then give rise to this disease. Also, contaminated honey has been implicated in outbreaks involving neonates. Wound botulism is a growing problem in injection drug users. Anaerobic conditions are necessary for the organism's growth. So it is a type of infectious disease that can be, the food can be the source for this infection, giving rise to the neurological features. Yes. Now, ingestion of extremely potent neurotoxin in even picogram amount causes predominantly bulbar and ocular pulses caused by neurotoxin, which is produced by this type of microorganism. Symptoms begin 18 to 36 hours after eating this canned food or vegetables. The symptoms may be started with difficulty in swallowing, slurred speech, also dry mouth, blurred double vision, ptosis. All these features are neurological features. Progression of the features can give rise to the limb weakness when the patient has flaccid, descending paralysis. Respiratory paralysis may be developed also. Also constipation, abdominal discomfort, abdominal pain, in addition to the nausea and vomiting. Now, how can we diagnose this disease, which is botulism? Of course, history and examination. The history by ingestion of these types of food and also by examination when we will find neurological features give an idea about the disease. Identify the botulinum toxin in the blood, serum, or stool. Show detection of the toxin that is the cause for this disease. Bacteria can be isolated from stool of people with foodborne and infants with botulism, not definitive test. Stool culture can differentiate botulism from other microorganisms like the E. coli and Salmonella. Brain scan, spinal fluid examination, EMG to differentiate from other conditions. So there are two types of investigations. Some of them diagnose the toxin or the microorganism, and the other investigations exclude other causes, give similar features like the certain neurological features by using imaging tests like the brain scan, spinal fluid examination, also the EMG for the neurological diseases. Now, what is the proper treatment for botulism? The proper treatment by using of antitoxin. This antitoxin block the action of the neurotoxin like the trivalent or heptavalent. This is antitoxin against the neurotoxin produced by these bacteria. Also, removal of the contaminated food from the gut by inducing vomiting or the use of the enema. Wound treated surgically because the wound may be the source of the infection. Of course, good supportive care is very important. Antibiotics are not used in foodborne but used in wound botulism. So, if the source of the infection by the wound infection, antibiotics here play an important role. A breathing machine with mechanical ventilation for respiratory failure, like the ventilator used in the previous case, which is presented as an example for the botulism. Yes. The other disease that discussed in this lecture is the tetanus. An example for the tetanus disease, 38 years old man with chief complaint of jaw discomfort and inability to open his mouth fully for 3 days. He also said he had struck his right shin with a hammer 10 days earlier, which penetrated deeply through the skin. And although the wound hurt and bled, he had not sought medical attention. So the patient has a trauma, and the trauma is neglected, and the patient then developed the jaw discomfort and inability to open his mouth fully. The patient had no history of medical or surgical procedure and had no known allergies and was not taking medications. This statement to exclude other possible causes for his clinical features as being with jaw discomfort and inability to open his mouth. Now, he had received his primary tetanus series in childhood, and his last booster was definitely more than 10 years ago. Also, he has vaccination against tetanus. So, in this situation and in this case scenario, we have to think in the possibility of a tetanus as the disease. Tetanus is the infection with specific microorganism that is Clostridia tetani, which is a commensal in the gut of the humans and domestic animals, which is found in the soil. Infection enters the body through the wound, often trivial wound. Just when the wound is contaminated by this microorganism can be the source of this disease, the source of this microorganism, and then this dangerous disease. Occurring mostly in gardeners and farmers, but with recent increase in intravenous drug misusers. In childbirth takes place in an hygiene environment. Tetanus neonatal may result from infection of the umbilical stump. This term what is called tetanus neonatal, or the mother may develop the disease. Mortality rate can be nearly 100% in newborn and around 40% in others. In circumstances unfavorable for the growth of the organism, spores are formed, and these may remain dormant for years in the soil. So, the spores may be the source of the infection. Then spores germinate and bacilli multiply only in anaerobic condition, which occur in areas of tissue necrosis or in oxygen tension in low, or if the oxygen tension is low as a result of the presence of other organisms, particularly aerobic ones. The bacilli then remains localized but produce an exotoxin with an affinity for more nerve endings and motor nerve cells. So the problem, all the problem, by the exotoxin that produced by this microorganism. This exotoxin has affinity to the motor neuron cells and also to the motor nerve, and this is the cause of the trismus and other clinical features, as we will see here. The anterior horn cells are affected after the exotoxin has passed into the bloodstream, and their involvement results in rigidity and convulsion. These are neurological features caused by the neurotoxin, which is the exotoxin. Symptoms first appear from 2 days to several weeks after the injury. This is the incubation period. The shorter the incubation period, the more severe the attack and the worse prognosis. Now, what are the clinical features that the patient can develop these symptoms? Trismus, which is spasm of the masseter muscles, which causes difficulty in opening of the mouth and in masticating. Hence, the name is lockjaw. So the first clinical feature is the lockjaw. Lockjaw in tetanus is painless, unlike the spasm of the masseters due to the dental abscess, septic throat, or other causes. So the lockjaw can be caused by other causes rather than tetanus, like the dental abscess or the septic throat, but here in these situations there is pain with the lockjaw. Conditions that can mimic the tetanus include the hysteria and phenothiazine overdosage or overdose in intravenous drug misusers. Okay, so the differential diagnosis is hysterical attacks for the patient or the overdose with phenothiazine or other drugs. The tonic rigidity spread to involve the muscles of the face, neck, and trunk, so it is not only localized to the mouth but also involve other areas in the body. Contraction of the frontalis and the muscles of the angles of the mouth lead to so-called rhizus sardonicus. Yes, rigidity of the muscles of the neck, trunk of varying degree. The back is usually slightly arched, what is called opisthostonus, and there is a broad-like abdominal wall. So there is a broad-like abdominal wall because of the contraction of the muscles, and the patient may develop also a slightly arched back, what is called the opisthostonus. In the more severe cases, violent spasm lasting for a few seconds up to 3 to 4 minutes occur spontaneously or may be induced by stimuli such as moving the patient or the noise. All these may cause stimulation to the muscle contractions. These convulsions are painful, exhausting, and very serious significance, especially if they appear soon after the onset of the symptoms. They gradually increase in frequency and severity for about 1 week, and the patient may die from exhaustion, asphyxia, aspiration pneumonia. So the causes of death could be the asphyxia or from the exhaustion or even the development of aspiration pneumonia. In less severe illness, convulsions may not commence for about a week after the first sign of rigidity, and in very mild infection, they may never appear. So the convulsion may occur and may not occur. If the condition is mild, maybe no convulsion, but if the condition is severe, then the illness there will be severe convulsions. Autonomic involvement may cause cardiovascular complications such as hypertension. Also, autonomic nervous system may be affected due to certain systemic features like the hypertension. Rarely, the only manifestation of the disease may be a local tetanus. It is very rare, in which there is stiffness, spasm of the muscles near the infected wound, and the prognosis here is good, of course, if the treatment is commenced at this stage. So maybe, rarely, localized infection with localized contraction of the muscles and good prognosis. Now, what are the investigation for this type of disease, for the tetanus? Diagnosis made mainly by what? By clinical grounds, because of the history and clinical findings. It is rarely possible to isolate the infecting organism from the original locus of entry. Now, how can you manage patient with tetanus? Four major points, which are the neutralization of the absorbed toxin is very important, and prevention of further toxin production, control the spasm of the clinical feature spasm of the disease, also general measures as maintenance of the hydration and treatment of secondary infection. Now, how can we neutralize the absorbed toxin? By IV injection of 3,000 units of human tetanus antitoxin, which is which must be available in the emergency room. Also, prevention of further toxin production by debridement of the wound and the use of the antibiotic, which is benzene 600 milligram IV 6 hourly. And if the patient is allergic to benzene, then we have to use metronidazole instead of the penicillin. And also we have to control the spasm by a quiet room and avoid unnecessary stimuli and the use of IV diazepam if the spasm continue. And even we paralyze the patient and ventilate the patient. Okay, by this way we control the muscle spasm. And general measures, as I said, by maintenance of the hydration and nutrition and treatment of secondary infection if it happened. Okay, thank you.